With these few words now, I would like to invite Dr. Preetham Kumar. He's a well-known pediatrician in Twin Cities. He did his undergraduation from Usmania and post-graduation from Nilofer. He's an intensivist and director of consultant and one of the directors of Rainbow Children's Hospital.
I thank IAP, TCB for giving me an opportunity today to speak in front of you. And let me get into the topic right away. I would say, as Dr. Bhaskar had said, yes, counseling these days has become very important, and communication skills definitely are playing a major role in how you practice and where you go from there. Now we'll see why it is so important here. Now the aim of the talk for today is why do you need to counsel, how to counsel, what are the points to be included in the counseling, whom to counsel, and how to document. Now what is counseling? Just a brief few sentences about counseling. It is a process where the messages are generated by one person and received by the other person. Okay, so it establishes an ongoing relationship between the patient and the doctor. Of course, it provides exchange of information basically needed by the patient to understand what is going on with the child, whatever his child is, how is it helping him, and what are the things which are going right or wrong with his child. So it all ultimately helps in having a better bondage between the doctor and the patient or the patient attendant. Now, what is the big deal about this counseling? I'll just talk about one real-time scenario where this happened actually in one of our hospitals. So this is a child, 13-year-old boy, who was brought to the casualty of a hospital at 10 o'clock with cough, fever and breathlessness of 3 days duration. And to complicate, this child was a child who was visiting from America. So you know what it is, okay? So this child was admitted to the ward, but however, in view of increasing restlessness and tachypnea, was shifted to ICU of another hospital at 2 o'clock in the night. So that is 4 hours after admission, this child was shifted to some other hospital, thinking that this child is not doing well. And at that Y hospital, the child was intubated and shifted to Z hospital because of parental request at 4 o'clock in the morning. So ultimately, 6 hours has elapsed after the child got admitted into another hospital. Labs and X-ray was done at the Z hospital, and bedside echo showed cardiomegaly with poor contractility and ejection fraction of 8%. This was somewhere around 6 o'clock or 7 o'clock in the morning. And parents were counseled about the various therapeutic options, and the other tests like your troponin and all those things started coming at 9 o'clock. So then probably the diagnosis was clear, it was probably a viral myocarditis. And that is when the parents were counseled about the various therapeutic options and bad prognosis associated with a severe myocarditis. The parents, you know how the NRIs are, they wanted to pursue all possible options, and they shifted the child to another hospital for ECMO at 12 o'clock. So that means after admitting into the Z hospital, the child took 8 hours to get to another hospital. And once the child got shifted, immediately the child arrested in the emergency room of that hospital wherever the child was shifted for ECMO. Now, the parents started to look at legal angle for it. They were looking at medico-legal implications. Now, as probably doctors who have been here practicing for so long, we wouldn't find anything wrong with it, because the child was admitted at 10 o'clock in the night, and by 12 o'clock next day, which is 12 hours, and in the night, that too, the 12 hours were in the night. So that 12 hours, the child was shifted to another hospital for whatever was required. But the parental contention was ECMO option should have been given earlier. When it was diagnosed, when they could find out at 6 o'clock in the morning that the heart was not beating well, why was not ECMO offered then? At least probably the child could have survived better. So that is what is the expectations these days. So the moral of the story is the expectations are rising. So unless we rise to the occasion, things can always get wrong or bound to get wrong. Okay. So now we get to the proper counseling. What information do we need to give in counseling, and how do we do the counseling part? Definitely medical profession has certain duties, and not fulfilling these can cause legal implications. And the basic primary thing is the therapeutic enlightenment and informed consent. Now these are the primary duties what you are supposed to discharge as a physician. Okay. Now what is this therapeutic enlightenment? The therapeutic enlightenment is basically to give the various options available to the parents and give them which is wrong, which is right, and then discuss the risks and benefits of each of these options. Now that is what is the therapeutic enlightenment. And the informed consent. The informed consent is about the possible and necessary treatment so that the patient can make a self-informed decision about treatment and non-treatment. Let's say, like you have a central line. You want to place a central line. We all know it is very essential. But for the central line, you need to put you need to take a sedation and you need to take a consent. Now the consent for what? Suppose you're putting an IJ line, you can rupture the carotid. And sometimes it can be very risky. You can cause an pneumothorax, and that little bit of fluctuation might be enough to take the life of the child. So that is all the more imperative that you take the consent, inform the possible complications which can arise out of these intervention, and then take it from there. Otherwise, technically, you are liable to be sued for anything. Suppose you do not tell all these things, you are liable to be sued. Okay. So it is important that we do all these things when we take any procedure. Now regarding the therapeutic enlightenment, if you talk about it, so what is it? Like suppose you are using one modality of treatment. Let's say in Kawasaki disease, you are giving immunoglobulins. Now, as physicians, we know it is important because that is the mainstay of treatment. But immunoglobulin per se carries some risks of HIV, hepatitis C, and all those things which are bloodborne diseases. But unless you counsel and then take a valid consent, suppose tomorrow the child develops something because of that or any other virus like the prions and all those things are there in these immunoglobulins. So anything goes on tomorrow, you are legally liable. I'm sure you might have heard about HIV being transmitted through blood and blood products initially, and there are a lot of doctors who were taken to court and also for Human Rights Council because of transfusing these bloods, even though the doctor was never responsible because we just get it from the blood bank and transfuse it. We are not doing anything else. Technically the blood bank should have been responsible, but it fell on the doctor because you have not counseled. You have not counseled that this blood product carries a risk of HIV, and HIV can be in the window period. So it's always important that you therapeutically enlighten the patient and also give the various possible options available. Okay, informed consent. Informed consent is basically, it is the responsibility of the patient to receive it. As a doctor, it is your primary responsibility and duty to give all the possible complications arising out of the procedure, and it's a duty, it's a right of the patient to receive it. So anything, he can always sue you tomorrow if you have not documented this informed consent or you have not given it properly. Now this is very important. Proof that information was delivered to the patient is incumbent upon the physician. So that means it lies on the physician to tomorrow defend himself in court that I have given this information. So either you want to do it video counseling or you want to document it in the case sheet, it is your headache. But the proof has to be there. Okay, so that also is part of the counseling. Now how do you do a good counseling? Ultimately, it is each patient is different. Let me tell you, I mean, I'm sure all of you are experienced doctors and experienced pediatricians. I'm sure you know that each patient is different. So you cannot take things casually and say, okay, this is bronchiolitis, let me come back and do it tomorrow. You never know which one will go wrong in the night. So each patient is unique, and always build an alliance with patients to meet mutually understood goals of therapy, and importantly, listen to them. Some of them would have concerns about different things. Either they can have unanswered questions, or they can have a misunderstanding. The common misunderstanding is, after you see that Tagore movie, everybody feels that any patient who is on a ventilator is technically dead, unless proven otherwise. So those things have to be clarified to the patient. Sometimes we take the parent into the ICU, pinch the child, make the child move, and then take a video out of it and then show them that the child is alive. And occasionally when the child is brain dead or something, we do a echo on the child, show that the heart is beating, and then take a video out of it. So these days that's how the life is, or that's how things are going on. So probably it is getting difficult and difficult to practice. So counseling is becoming all the more important. And ultimately they can take their own decisions regarding treatment, and they may not reveal information to you unless you initiate a dialogue. So it's always important that you talk to them and listen to them. And communication during drug therapy, again this is very important, especially when you are giving a drug. It is important first to talk about what is the reason why you are giving the drug in the first place, and what is how the medication works, what is the dose and duration of therapy, goals of therapy, and how effectiveness will be monitored, and adverse effects to deal with them. So now, what we have done recently is we have put the medication chart besides the nurse, besides the patient. So the patient knows what we are giving. We know the patient is getting, let's say, cefoperazine or ceftriaxone twice a day. The dose is there, the route is there, and what time it is supposed to be given is there. So at least there is a auto counseling of the patient that, okay, my drug is this, there are 3 drugs for my child, so these are supposed to be given at these times. That's how things are evolving these days. And naturally, anybody who reads that would ask you next when you go, doctor, are there side effects with these antibiotics? Yes, you'll have to say yes. So those are the implications which are facing as time passes by. And effective counseling, always listen carefully before you speak, get rid of any distractions, use eye contact to show you are listening, read non-verbal messages. Non-verbal messages like, if the parent is not having an eye contact with you, then this is the person who can cause you problems. He has lost trust in you, or he is not trying to, believe in you. So these are the ones you should be more wary of. So these are some non-verbal messages. I think by experience you learn all of them, but initial stages in life, people, the PGs or whoever who are sitting here, remember, anybody who is not having eye focus is a potential bomb. And you look at proper feedback to clarify the message, and the important thing is make sure that the message you given to the patient is received properly. You might be saying the child is sick. The patient thinks that, are serious gaadle, sick parvaledle, baagayipotadu. So it is important that the message is conveyed, and take a feedback and make sure that it is conveyed properly. Now, what are the barriers to effective communication? The commonest things, physical. They catch you in the corridor and ask, sir, anta baage unda. The commonest thing you say is, okay. Then he catches that and would ask you, మీరు ఓకే అన్నారు కదా సార్, ఏమైంది మరి ఇప్పుడు? So it is always, there is a barrier for communication. It's a physical barrier where you have lot of noise, you do not have proper place to counsel. That is when you end up in these problems. The second is psychological barrier, where the mindset of the patient. Initial phase, the patient is in denial. Is more so happens with dengue and dengue shocks, because the child crashes very fast. There the patient is, sir, ఇప్పుడే వచ్చాం సార్, మేము 2 hours అయింది, మంచిగా మాట్లాడుతూ వచ్చినాడు కదా సార్, నడుచుకుంటూ వచ్చినాడు కదా సార్. So the patient is in denial. That is where it is the psychological barrier. And administrative or financial, the more you pay, the more expectations increase. Suppose you rake up a bill of 1 lakh, the patient feels that, yes, I have given 1 lakh to this doctor, the patient has to survive. So that is where again the barrier comes in. And fourth, importantly, is your time conflict. You have 10 patients to counsel, you take only 1 minute, that is where the problems arise. Because you cannot talk each of these goals, whatever you have discussed, whatever the management part or the information or the informed consent, you cannot give in 1 minute's time. So take your time, spend time with them, especially the sick ones, and then take it forward. Efficient counseling, always the same ones, whatever you have learned previously. Now, basics of a good counseling is beneficence. Always first tell the patient what he is benefiting out of the treatment. Second thing is honesty. Be truthful. Do not try to promise which you cannot deliver. If you are dealing with a viral infection or a dengue or something of that sort, be upright and tell, this is a virus. Now, I have my limitations. I cannot 100% guarantee the results. There is a element of surprise in these sort of viral infections. So it is always important that you be right and honest at the initial counseling, so that things go on smoothly. And informed consent, as I told, it is important that it is documented. Do not try to be pleasing or don't try to be detached. None of these works. If you are pleasing, the expectations from the patient increases. If you are detached, the patient starts to have loss of contact with you. Then don't try to take up tasks which you cannot perform or deliver. Now, whom to counsel? Again, can be tricky in some broken families. These days, a lot of divorces and all those things, it is getting difficult. The maternal side gets the patient to you, the paternal side thinks you are not the right doctor. So these are some tricky areas where you need to take care of. Ideally, parents and immediate close relatives are the ones you need to take care of. And in MLCs, it is better to involve the police in the counsel. Documentation, it is important to document the case, document all the questions which these relatives have raised in the case file, so that tomorrow you know what the patient has asked and what you have answered, because these are the questions which are going to come back to you at a later date through a lawyer. So it's better that you document them and write them in the case sheet that these questions were asked and I have answered these questions in this way. And better to write specific concerns. And counseling under a video is gaining wide popularity, because the parents would later on come back, or even if not the parents, some ex-relative would come back 2 days later and says, "Sir, meer anta baagayipothadannaru kada sir, enduku itla ayindi." So it is better that you have a proof. It acts as a deterrent. The parents would definitely mellow down when you have a proof and show them the proof that this is what I have spoken of. And ultimately, the consent also has to be taken for the recording of the counseling, especially the video part of it, the electronic recording. If you are doing it, you have to take a consent for it. So that finishes off my talk. Any questions?
On the case?
Yes, sir.
What is the best informed consent?
Yes, sir. It varies from a hospital to hospital though. But suppose you are looking at a medical consent, it might be a little different. If it's a surgical consent, it might be different. But what has always been contended in the court is that have you taken a specific consent for this patient? Let's say you have to write that this patient of dengue has been admitted. Anyway, the name and everything you will write, but this patient with dengue has been admitted. Or if I am putting a central line, this patient who has been advised central line placement under sedation has been counseled about the consequences of this thing like pneumothorax and all those things. So specifically things have to be written. It needs to be specified to that individual whom you are taking the consent for. Let's say it's a dengue, the consent is different. So sepsis consent might be different. Or you are giving a blood product, the consent might be different. Yes, sir. If you are transfusing within 2 to 4 hours, it's still all right. You can take one consent for those 2-3 things. But if you are taking again, transfusing today and tomorrow, you will have to again take a different consent.
Like and subscribe Eagle Media Works.